Cambridgeorthpaedics, Pelvic Trauma Part 3. Here we're going to talk about the remainder of lateral compression type fractures, type 2 and type 3. Case 2. This is interesting, isn't it? So we've got here what looks like maybe just an isolated iliac crest fracture. This is the level of S1, body of S2 visible. High energy, fall from a height, I believe, landing on their side. This is in the binder. This patient is not shocked, they're stable. But take the slice down a little bit, and it really does look like that iliac crest is not where it should be. Indeed, one could argue that this is actually the crescent that is left behind from this fracture, and I'm going to call it an LC2. And if people wish to disagree, I'm happy for them to do so. Okay, these are quite fun. Not for the patient, but in terms of a strategy for fixation, it's good to exercise the brain. So go into theatre, and what you have is an inlet view here, not the best inlet view, but an inlet view nonetheless. And what I realised is that there are two down the wings, and I'm going to do my best to look at the camera and describe this. So there's that iliac and 10 to 15 degrees over to get down the wing. Now on the crescent fracture, that's at a different angle because of the deformity to the constant fragment. So distally it's like this, and the constant fragment's like this. And when you marry those two up by your reduction manoeuvre, so it all becomes one line, you have a reduction. It's harder when it's segmental, and in fact it's probably not that reliable when it's segmental. So my strategy here was to put a shank pin in the crest, so come back pelvic model. So if we're looking here, what's the best way to describe that? Here, I'm putting a shank pin in the crest just distal to where the fracture line is. Okay, I'm parking up a guide wire which goes from the AIIS, aiming along this column of bone to the PSIS, making sure it's safe on my iliac oblique view. And get it parked up. That guide wire is parked up. It may not be perfect, but you want some stability to return. And then as you do a reduction manoeuvre, which is a pull of that distal component back out, things line up on the down to wing views, got my reduction, happy days, pass a guide wire, but one's never, well, one probably is enough, but I like two. And the more screws, the better. I've had to slightly unwind the shank pin here because it was getting in the way, acting like a blocker for the LC2 guide wires on the LC2 screws. And things look like they've lined up on the down wing. And as you put the screws in, because they take up volume, they also help line the bone, a bit like a tibial nail. And here we can see on this iliac oblique entry point over the AIIS, and here's a sciatic notch, there's the fracture coming down to the SI joint. So we've got two good partially threaded screws beyond it, which are divergent, and they're creating compression across the fracture line. And I like this. This is a nice technique. What's nice is also because they're divergent, you've got rotational control. You've got one screw there, fracture's held here, and it's held nicely. So bit of spread, bit of separation of the screws equals greater hold. Here we are, rotational. Once you've got your reduction, rotational alignment looks great, right? Spinous processes line up with symphysis. Happy days. And all we need to do is establish some form of fixation at the front. Now that could be a choice. That could be an external fixator, a big smiley U-plate, or bilateral antegrade column screws. That would have been very awesome. Or an internal fixator, which would be equally appropriate, and that was what was done in this scenario. Case 3. Hey Siri.
Yes.
Alright, here we got a pretty interesting fracture pattern. And there are lots of clues on this CT scan. Okay, so let's go through it. Right. This is the CT scan is slightly awesome. So we have a Denny zone 1 extending into 2. Full thickness, complete lateral compression fracture here. There's more. There's more. Let's look at this SI joint. This SI joint looks normal and closed. Compare it on this beautiful axial axial CT slice to this side, and this side looks different. So your suspicions should be that this is an LC3 type pattern of injury, i.e. one side has had compression, which had an arrow, and the other side has gone into external rotation. If only there were better sound effects that were possible. But so one side has gone in, donk, and the other side has gone out, donk. Perfect. So this is an LC3, and I hope that's all clear. No great deformity on this one, I have to say, but there's more to follow. That SI joint is really much more visible on this coronal view, right? You can really see that it's opened up. And you can also see that there's comminution on the LC side, which is annoying and an indicator of instability and an indicator that I can, unfortunately, overcompress this pelvis if I wish to. And the eagle-eyed amongst you, right? And there are some eagle-eyed people. They will spot that, look at this posterior column. This looks fishy, this does. So this is an LC3, but with a combined component to it. Here's another one, just to reiterate the point, and this is a lovely X-ray, very unfortunate injury. All right, catheters in. That isn't the first thing you should spot. Proximal femoral fracture with gas around it. Open proximal femoral fracture. Something going through here. Looks like this could be either an acetabular fracture as it goes through the foramen. The sacrum is facing us. Yet this is looking like an obturator view. So you can see anterior column down here, and I can see the posterior wall. This is an obturator view of this side, and yet this now is almost like an iliac beak of the other side, yet the sacrum is facing us. So basically this is an extreme windswept deformity in this poor individual. Okay? Now, windswept deformities, think an LC3. And it kind of makes sense. This SI joint looks wide, even though it's not a proper view. And if you square up the pelvis, more features are revealed, but the spine's pointing the wrong way now. And we got this here, it's crescent. I'm going to call it a crescent. Maybe an anterior column fracture, but I'm going to call it a crescent, okay? It comes into the SI joint, and this SI joint looks wide, and we got these bilateral root rami fractures, which I wonder how these really fare. So here's our inlet view. We can have a suspicion of a wide open SI joint on the left hand side, and that's the crescent coming into the sacral iliac joint, and then testing it, a bit of a figure of 4 position on that left leg really opens up that SI joint quite dramatically, which closes on a bit of compression. So my strategy on these fracture patterns is to fix the AP-sided injury, okay, because that restitutes, that's a hard stop, right? We bring the SI joint back together, that's a hard stop, it can go no further, okay, so that should restore the midline. So using a screw, single unisacral because it's dysmorphic S1 screw, but also unisacral because you don't want to fix the other side in an open position, more an uncompressed position. So unisacral S1 screw, avoiding the foramen on this lovely outlet view where we can see a little bit of rotational malalignment, lovely for foramen and visible to us, nice and safe. getting ready for the transsacral S2 screw. Don't forget here we can go transsacral because it's a crescent fracture at the other side, it's not a LC1. Bit of manipulation of guide wire trajectory using a bent wire technique and a drill guide to get it nice and safe across that foraminal corridor. Bit of over drilling of this side just to create some wiggle room for closure of the SI joints, and the use of washers to help close it down. And it does close it down, and you'll see that on the CT scan I've got later on. This is definitely on the verge, this unisacral S1. I'd be a bit worried if it went any further than that into that recess. And what we can see here is that so much force has been applied, and I'll explain later, that it's actually crumpled through the outer table. And two divergent LC2 screws supported by an infix, and a percutaneous reduction of the anterior root of ramus, because I want some continuity at the anterior structures to reduce his risk of a non-union. I think there's a high morbidity yet to be proven about the floating pubic symphysis. And an ACS just to support that construct. Poor chap did get an infection from his proximal femur. That was done on a separate occasion prior to the pelvis being performed. And these are him 6 weeks post-op, and he looks like he's got a reasonable return of pelvic symmetry and a confusing amount of metal work. And this is him united at 8 weeks, right? He looks like he's going the right way. So now we're just strategizing taking out the infix over the next 2 to 3 weeks. This is a scan, and this is why I wasn't so concerned about compression through the outer table, because this SI joint is closed. It's symmetrical to the other one, as you can see at both S1 and at S2. Alright, so that is a brief run through. Alright, that is a brief run through of the lateral compression type injuries. We've talked about a bit about epidemiology. We've talked about the tile classification, and we've talked about Young and Burgess. But we're talking about how to do an EUA effectively, looking for the unexpected, and about the strategy for fixation. More to follow.